Good afternoon and welcome. My name is Molly Mitchell. I am the coordinator of the Mid-Atlantic Public Health Training Center, and on behalf of the Training Center and the Department of Health and Mental Hygiene and the Region 3 STD HIV Prevention Training Center, I'd like to welcome you all to today's presentation on syphilis in Maryland, populations at risk. Before we get started with today's presentation, for those who are watching online, I ask that each of you please take a second and sign into today's presentation. That way we'll have a better count of how many people are actually watching for our federal funders. We also ask that you, if you have any questions at any point during the webcast, please just click on the link to email a question to the presenter, and that email will come through. I'd also like to just take a second for those online to please take a look at our other trainings that are coming up from the Training Center, which include next month's Grand Round presentation on water safety on May 18th, using social marketing to influence decision makers, working with interpreters, and cultural competency train the trainer. And with that, I'd like to go ahead and turn the floor over to Barbara Conrad. Barbara Conrad is the chief of the Center for Sexually Transmitted Infection Prevention at the Maryland Department of Health and Mental Hygiene, Infectious Disease and Environmental Health Administration. Thank you.
Good afternoon. I'm Barbara Conrad, and we really welcome this opportunity to help get the word out about syphilis, which continues to be a very significant concern for us here in Maryland, and we know in many other parts of the country. Today, we'll be hearing from Dr. Rompalo. She is a professor of medicine at the Johns Hopkins University School of Medicine, Division of Infectious Diseases, and in the Department of Obstetrics and Gynecology. She holds a joint appointment at the JHU Bloomberg School of Public Health in the Division of Epidemiology and the Division of Population, Family, and Reproductive Health. She is a noted provider in the field of infectious disease and is an internationally recognized expert in the field of sexually transmitted infections, STIs. For 20 years, Dr. Rompalo has been the medical director of the Region 3 STD/HIV Prevention Training Center and has recently been designated co-director of the National Training Center for Family Planning Services for Men. Additionally, she serves as medical consultant to the State Health Department's Center for Sexually Transmitted Infection Prevention, co-sponsor of today's webcast. Dr. Rompalo has authored more than 150 peer-reviewed articles, several chapters, is an editor and expert reviewer for several journals, and serves on multiple national and international advisory, conference, and scientific committees. Welcome, Dr. Rompalo.
And welcome everyone here and on the web. So let's begin. Maybe we will, and maybe we won't. Let me go down. So before we start, I'm going to talk about continuing education. The CDC is giving us continuing education credits. I have no financial conflicts. A lot of wording here, but basically we're not going to talk about anything that is unruly or illegal. And if you get through this, you'll get 1.0 AMA PRA Category 1 credits, but and non-physicians will also get a certificate of participation. More information if you want it. And here is the continuing education credit available from the CDC. You'll see this again. Specifically, I'll show this slide at the end, but this will instruct you on how to get these valuable credits at the end of this lecture. So let's start. Hopefully at the end of this lecture, all of you here and on the net will be able to define populations at risk within your specific regions and recognize the common signs and symptoms, and this is going to be primarily of early syphilis. Choose and correctly interpret diagnostic tests for syphilis and describe the appropriate steps for syphilis reporting and partner notification. So with the public health spin, this is actually public health and control in action, taking it from bedside to bench and back to bedside into the public health. So who's at risk? And if you're interested in more information, go to cdc.gov/STD, specifically syphilis, and you'll get, well, a lot of information on this. And I'm going to highlight some of this information here. These are the most recent data of primary and secondary syphilis. And remember, primary and secondary syphilis are the stages of syphilis which are infectious. And that's why we spend so much time on this. And these are the rates by sex and male to female rate ratios in the United States. And what you can see here are two things: that males are predominant in the number of cases that are being recently diagnosed, and that syphilis is not going away. Where is it? These are rates by region. What we see here is the South accounts for over 50% of the new cases or primary and secondary infectious cases of syphilis. During the 2008 to 2009, the rates actually in the South increased by 10%. And it's increased in every single region except in the West, where there was a slow but significant decline. Looking at the rates by state, this slide illustrates that there are 13 states with the highest rate of primary and secondary syphilis. And this accounts for 75% of all the cases of PNS syphilis. 10 of these states are in the South. If you want to zoom down into counties, the good news here is that over 2,000 counties in the United States, of the 3,000 counties, over 3,000 counties that we have no syphilis cases. But there are other counties that are heavy with syphilis, and we have to pay attention. If any of you are listening from these 29 counties and 2 cities, and the 2 cities will remain, you know who you are, pay attention to syphilis in your area. Who's getting this? Well, in 2009, the rate of primary and secondary syphilis, as shown here by sex, was the highest among persons who were ages 20 to 24 and 25 to 29. And you can see there's a discrepancy here. There's much more males than females being diagnosed, as I talked about. But the peak for males, you can see, is here. I think I can show you this, yeah. 20 to 29. But look, the rest of the ages here are also significant. In females, we have 2 areas that are high, and that's among the 15 to 19-year-olds with a peak in the 20 to 24-year-olds. So both young men and young women are becoming infected with this disease. There is discrepancy by race and ethnicity, as you can see on this slide. African Americans accounted for half of all the primary and secondary syphilis cases in 2009. And the rate of primary and secondary syphilis among blacks is 9 times higher than whites and 4 times higher than among Hispanics. Looking at cases by sex and sexual behavior, as well as race ethnicity, you see on this slide that among young black men ages 15 to 24, there continues to be an increase, and the increase is significant. So significant that this is becoming a very concerning trend. Between 2005, which is not shown here, but between 2005 and 2009, PNS syphilis rates among young black men in that young age group, 15 to 24, increased. Actually, it tripled. And this trend is disproportionately high among HIV-infected young African American men. And remember, HIV and syphilis go hand in hand. They potentiate each other. It's good news if you have syphilis and HIV for the syphilis and for the HIV, but it's bad news for the individual and for society. The next slide shows reporting by source, and although many of us feel that syphilis is being reported and diagnosed in STD clinics and it's their problem, actually this slide illustrates that among men, most of the cases are being reported from non-STD clinics. So everyone needs to be aware of this infection. To round things off, here are the congenital syphilis rates. Overall, the rate of congenital syphilis decreased in 2008 to 2009, and that's good news. However, it is still there and among us, so we need to pay attention. primary and secondary syphilis and HIV. What I wanted to show here, this is from the specific areas that follow HIV and syphilis that is called the STD Surveillance Network, and they're reported to the CDC. And what I want to show you here is that among the three leading cities, Richmond, Baltimore, and Philadelphia, and these are in our region, we are the highest. The rates go from the lowest, which I will tell you was in, let me be sure I say this right, the lowest rates were in Birmingham, and the highest rates, unfortunately, are here in Baltimore. So we need to be aware, and we need to be vigilant on the diagnosis. So how can I share these data with you? Where do we get these data? Well, we get these data because it's the law that we report it. Maryland law, and I think I can speak for all of the states, require and regulate the reporting of syphilis, gonorrhea, and chlamydia by both the laboratories and healthcare providers. This dual reporting system, it's intentional, not just one, but both, because clinical and demographic information that you, and if all you're listening are providers, that you provide, the laboratory doesn't have. And this enables the Department of Health to better monitor disease trends. Who's getting it? Where are they getting it? What states need to be, as you saw, worried about this, and even what county and blocks need to be aware of what's going on. So please, if you're listening, complete all the demographic information on the lab form. And I'll show you this toward the end. So the summary points for this beginning section about the epidemiology is that nationwide, the rate of infectious syphilis increased about 4% among men during the 2008-9 period, with a male-to-female ratio of about 5.6. It was highest among persons aged 20 to 29. It increased in all racial and ethnic groups except non-Hispanic whites and Hispanics, and most cases are reported from sources other than STD clinics. So if we look at special populations, as the CDC calls them, and they're listed here, the tick marks show you who among these special populations are at risk for syphilis, and particularly men who have sex with men, adolescents and young adults, racial and ethnic minorities. And I'm going to say we have to pay attention to women and infants and people entering correctional facilities. So keep your eyes wide open when it comes to screening for syphilis. So who's at risk here in our region? And then I'm going to throw, if you're not from our region, I'm going to say you should find out who's at risk in your particular region. If there's anyone here listening from, I don't know, Hawaii, California, Alaska, well then that's your task. In Maryland, here is the Maryland National Rankings for Sexually Transmitted Infections. I'm just going to talk about the rankings. You can look at rates and U.S. rates comparatively. But for syphilis in 2008, we were 5th. Now we rank 12th. For congenital syphilis, however, we were 3rd. Now we rank 1st. For gonorrhea, 19th. Now we're 16th. And for chlamydia, 15th. And now we're 17th. So there's a shift here, up and down, up and down. We're not quite out of the woods. And you know, you can probably superimpose your state here and find the same things. Okay, all of you who are listening from Maryland, pay attention. This is our state, and this is the incidence rates by jurisdiction, and Baltimore City is a hot spot. But don't get so relaxed, because there's other very, very warm or bordering on hot spots throughout the region. So these are our most recent 2009 data, and we'll see this again if you're going to come to our meeting in May. We also have the primary and secondary rates and congenital syphilis cases. Although the highest rates, again, just like nationally, are among men, with rates relatively low among females, we are seeing this increase in congenital syphilis rates. You know, it may be because we're doing a great job in reporting the cases, and you have to pay attention to that. But nonetheless, we all should screen pregnant women, and I'll talk about that toward the end, and continue to do that. This is PNS syphilis reported cases among males by mode of transmission and race ethnicity, and you can see on this slide that for Maryland, our MSM have higher rates than heterosexuals, but among African Americans, they have the highest rate among MSM in the state. So we have to look, we have to screen, and we have to be aware. The other thing that we also have to be aware of, as I alluded to, syphilis and HIV go hand in hand, and these are the most recent data on HIV diagnosis by exposure category. And although the percentage of HIV diagnosis among heterosexuals has stayed basically the same, and I will say good news, it's going down among injection drug users. Bad news, it's going up among MSM. So let's go down the Beltway. Let's move down a little bit, down 495, and see what's happening in D.C. Because, you know, we're Baltimore, Maryland, but D.C. is part of us too, as well as Philadelphia and anyone else listening here in the region. Primary and secondary syphilis rate by gender and number of reported cases is high among males in D.C., although they peaked in 2007. They're really high in 2009 too, so the ratio currently is 15-1. We can see that in race and ethnicity, the number of reported cases are highest among African Americans, but I will say the one thing I have just highlighted, there's like 11% other or unknown. And I'm going to say again, it's up to us to report the information to our district so that there's not 11% of I don't know what the people are. The lab won't, but we as clinicians will. So please fill out those forms. And here is a very interesting slide that was shared with us from Washington. The reported cases of primary and secondary syphilis. People come in with co-infection with HIV, so they have HIV and syphilis. When they walk in the door, there's about 326. The percentage of these co-infected individuals were, and this is men who have sex with men, among men, were African American, 54% shown here. But look, 72% of these co-infected individuals knew they were HIV infected and got a new case of syphilis. Again, driving home the point that if you see HIV infected individuals in your clinic or in your patient population, don't assume that they're not having sex or don't assume that they're not having unsafe sex. Ask the question, how's your sex life? If they say, great, I met a new partner, screen. And this is according to CDC, IDSA, the U.S. Preventive Task Force Services recommendations to screen HIV-infected individuals for STDs to hopefully decrease HIV and STD transmission. The word's prevention. So who has infectious syphilis? Well, it's up to us as clinicians not to miss certain things. And I'm going to focus on primary and secondary disease. Remember, syphilis is easy to cure in its early stages. And the signs and symptoms of early syphilis include, and I'm going to show you what my kids used to call the yucky pictures, and I don't want to put you off your lunch, those of you who are eating, but here we go. It includes a firm, round, small, and painless sore on the genitals, anus, or mouth. Anywhere you have sex, this can happen, okay? And even though I say the classic textbook presentation, I will warn you, syphilis doesn't always read the textbook. Therefore, you can have unusual presentations. Watch for a rash on the body, especially on the palms of the hands and the soles of the feet. But remember, you can have a rash on the trunk and not have palm or plantar involvement. So any rash determines consideration, especially if I'm pregnant, especially if I'm HIV infected. You should think, maybe I should do a serologic test for syphilis and check the results. Now, why am I focusing on primary and secondary? Because primary, secondary, and early latent, which is defined as within the year of acquiring syphilis, are the infectious forms, the very infectious forms of this disease. So for prevention and control, in this lecture, I'm going to focus on these and what not to miss. And here we are. These are brilliant slides by Dr. Bingham, who works in or is retired recently in England. And if you're interested, it is a beautiful pocket picture guide to these. And this shows two forms of chancre. Remember, chancres begin as macules, which soon become papular and then erode and form the ulcer. And sometimes it has a brilliant, nice edge, and sometimes it's very subtle. And this gentleman has, I'm going to show you here, he has a small ulcer on the glands of the penis right there. So, it's not always beautiful punched out lesions. It can be subtle. So think about it. This is a woman with the classic kissing ulcers on the labia majora. And here I'm going to show you, which sometimes we miss and often don't see, primary chancre of the cervix. The patient has no means of knowing when a chancre appeared on her cervix. She probably doesn't even know it's there, but she is very contagious. Here's 2 oral chancres, beautiful punched out lesion on the tongue. But here's a lesion that's in the back of the throat that is very reminiscent of what I just showed you on the cervix. Let me see if I can get this mouse to work. Okay, the mouse doesn't want to work, but you can see in the back of the throat that there is a granular type of lesion. This is a chancre. Why doesn't it have the classic punched out definition? Because the architecture of the skin is different than the squamous versus the transitional epithelial or columnar epithelial in the back of the throat. Secondary syphilitic rashes. Syphilis can look like anything as a rash. It can be macular, it can be papular, it can be pustular, it can be any of these combinations. It can be generalized or it can be pinpoint. It can fool you looking like psoriasis. It can look like anything. Here's a relatively mild rash. Here's a rash on the chest, which is both macular, papular, and some pustules. And here's the classic secondary palmar plantar manifestations on the palms and the soles. And you can look up closely. There's almost like a desquamation piece to this. These are condylomata lata, which are heaped up warty-looking lesions. They are not warts. They are teeming with spirochetes. They are highly infectious, and they occur not where you have sex, but in warm intratriginous areas and warm areas. So between the scrotum and the penis here, scrotum and the thigh. I think I have, yes. This is 2 women around the gluteal fold and labia majora minora. They look like warts. They're not. Remember, warts are dead skin. These are secondary oozing lesions, which are teeming with spirochetes. Mucous patches, finally, on the mouth. Things to look for, flat patches that can be on any mucosal surface. You might find this in the vagina, in the throat, down the esophagus, but mostly it's in the mouth and in the tongue, even in the rectum. So, how do you diagnose this? What not to miss? Well, the diagnosis of syphilis is a challenge. Clinically, I've been telling you what not to miss, but clinical diagnosis is poor because there's a wide spectrum of illness, and as I was trying to drive home, you have to have a high index of suspicion. Lesion-based tests, which allow visualization of the treponeme, are great, except you need a dark field microscope. And you need special antigens to do this, which have been taken off the market. So what we do, many of us are diagnosing syphilis in the latent stage where there's no signs and symptoms, and we do a blood test. And that's fine, but again, we're trying to drive the more primary, secondary diagnoses to be aware of, to report, because these are most contagious, infectious, and these are the people we want to find, treat, and intervene with their partners. Well, then you might be thinking, well, why not just do a culture of all those nice juicy lesions? Because we can't culture Treponema pallidum. Okay, you might be thinking, well, why not just go after it with polymerase chain reactions? We have all these really nifty new tests. Well, they're only used in research settings, and it's not commercially available. So we are stuck, and I mean stuck, with serology, which happens to be right now the cornerstone of diagnosis. There are 2 types of serologic tests for syphilis. This is the classic algorithm that I'm going to talk about, and then I'll talk about the new, I don't know if it's improved, but the new algorithm that we will be using, and I'll talk about why it came about. So there's 2 types of serologic tests. As we talk about, since I'm in the School of Public Health now, we have a screening test and a confirmatory test. Screening tests are cheap, fast, and efficient. Confirmatory tests tell us, they confirm the diagnosis, and this is what we use. nonspecific, nontreponemal antibody tests, which are directed against lipoidal antigens. Okay, these are antigens that are released from a damaged host. It's probably caused by the treponeme. So the treponeme gets into my blood vessels, wreaks havoc, causes leakage, and these tests pick up that lipoidal antigen that's oozed from the destroyed tissue. Okay? This is both qualitative, plus minus, and a quantitative. It gives you a titer. I'll talk about that in a second. If this is positive, what we usually do or used to do is a more specific antibody test that's directed against treponema pallidum proteins, which is spelled incorrectly, and I apologize. This is a qualitative test. It should only be positive or negative. So the CDC says we need both types of tests, screening test, confirmatory test, to make an accurate diagnosis of syphilis. But herein lies the rub. The sensitivity and specificity of these serologies vary by stage. And, to make matters worse, the presence of antibody doesn't distinguish past from present infection. Ah, yes. So, here's what we have, the non-treponemal tests that are in your armamentarium to make a diagnosis. They're nonspecific, remember, we talked about that. They all have relatively equivalent sensitivity, positive when you have the disease, and specificity, negative when you don't. And it takes about 3 to 4 weeks after exposure. So, if I have sex on Friday night with Prince or Princess Charming and they have syphilis and they inoculate me and I come in to see you, I won't have enough time to make an antibody-antigen reaction. So it will be negative. Or even when I have a primary chancre, it could be negative because my body hasn't caught up with the fact that I'm infected with syphilis. But the good news is that these tests, when they're positive, are reported in a reciprocal titer, and I'll show you that in a second. And this titer somewhat, not always, again, correlates with disease activity. However, we do use titer decline to document response to therapy. Why? Because we don't have cultures, because we don't have any other way around this. Okay. So this is usually, anybody's listening to this in the clinics, you know this algorithm. What we're trying to do is cause the titer to decrease at least 4-fold. So if I start out, let's see if I can make this work. If I start out at 1 to 32, I would like to go down times 2, 1 to 16, times 2, 1 to 16, 1 to 8. This is a little bit off here. But I would like to go down at least 4-fold after therapy within a reasonable time frame, which is usually 6 months to a year after primary and secondary syphilis. And that means that the therapy worked. My titer has fallen more rapidly than it would had I not been treated. And that's the whole gist of this following the titers. All right, what are the the treponemal antibody tests, the specific tests? These are either fluorescent treponemal antibody, treponema pallidum particulate agglutination, or ELISA tests. These tests are very good. False positives are possible, but they're uncommon. They usually become positive before a VDRL or RPR, but not always. Not so much that we always screen for these, and they remain positive for life. So you can't follow an FTA titer and you don't get one. You get positive or negative. And even if you're appropriately treated, this test may stay positive for life. And this is a diagram of how these act over time. Just quickly, as you can see, this is sensitivity of the test. This is even without therapy. So it rises from primary syphilis over to secondary syphilis when you're most active, have a lot of manifestations of the disease, and if no treatment ensues, and let's pretend you go to an island someplace, a survivor, and have no medication and no therapy and no nothing, it will decrease over time. Whereas the FTA or the MHATP or whatever you're using, treponema pallidum particulate agglutination, which is also called TPPA, stays positive for life in most cases. Okay, well, many of you, as I talked about, might have HIV infected individuals in your patient population. How does that affect diagnostic tests? Well, there's actually little impact of HIV infection on these diagnostic tests. You will find case reports of false positive RPRs, for example, where the patient is actually infected, and rare reports of delayed or absent seroreactivity, where you have a secondary case of syphilis and everything's negative. That happens, but it's not the rule. Higher means higher mean serologic titers, meaning that we have the impression that HIV-infected individuals have higher titers of their RPR, and this can be the case. Yes, this happens. Again, it's not the rule, but I will say that HIV-infected individuals do have a slower drop in their serologic titers, about 25%, in a study done by Rolfs in the 1990s, showed that maybe 25% again decrease slower than the textbook said they should have. So usually with primary and secondary syphilis in HIV-infected individuals, you want to follow them closely every 3 months with titers because they're a very high-risk population, and we want to make sure that they respond. Okay, so Treponema pallidum can't be cultured. Serologic testing is the method most often used to diagnose syphilis. Screening is recommended for, now I'm talking screening, not testing, screening, doing a test. Persons at high risk, we want to detect latent infection. Okay, if I come in with a chancre or a secondary rash, you want to diagnose me, that's really not screening, that's a diagnostic test. But if I come in and let's say I have no signs or symptoms and I'm highly sexually active, or an injection drug user who's exchanging sex for drug, or someone who is a commercial sex worker, you want to screen me. You want to screen pregnant women, whether they have signs or symptoms or not. I'll talk about this in the end, to prevent congenital syphilis. And we always screen blood donors to prevent transmission through transfusion. And thank God that's a rare event these days because we're so good at screening. But here's the problem. Traditional testing to do this RPR and this FTA takes one technologist, and they have to do one test. And this is time and this is labor. So this leads to the adoption of a new reversed sequence screening in which the sera that I send is tested by a treponemal EIA or CIA. What does that mean? It's an enzyme and or chemiluminescent immunoassay. So instead of one tech, one test, you can run 100 sera on a card through this machine and get an automated high throughput means of testing. That for the lab is great. It's fast, it's efficient, it's less costly, less tech time, they can do something else. If that's positive, then you do the RPR or the VDRL or whatever your test is, the non-treponemal test. Okay. All right, so why we do this? This is the new screening. All patients have a screening. These are all ELISAs, EIA, CIA. Another way to call it is an ELISA test. And they're all IgG, meaning that they're late antibody reactions. If the ELISA is positive, then you do your your non-treponemal test, which is an RPR. And if you have to, if there's discrepancy, and I know some of you are thinking, oh my God, well, okay, you're right. If I have an ELISA positive and an RPR negative, there's discrepancy, then I have to do another specific test, an FTA or a TPPA. Okay, in some clinical situations, an RPR or an FTA is also ordered just regularly, and these are in patients with genital ulcers and you just want to be sure, so you send the order all together, or patients needing follow-up of a previously diagnosed case. Remember, I told you serology is not going to tell you if it's old or new. Here's the advantages. I'm not going to spend time. We talked about this. They're faster, it's automated, it's less expensive. And this is the algorithm. So here you go. I'm going to spend a second on this because it's worth mentioning. Okay, let me get my little mouse working for all of those that are out in webland, if it works. You do an EIA or a CIA. Here you go. If it's negative, stop, done, you're finished. If it's positive, then you go on to do an RPR or a VDRL if that's what you have. If you have a positive EIA and a positive RPR, okay, syphilis is there. The clinician has to decide, is it current or is it a past infection? Now, here's where you get into trouble. If the EIA is positive, but that RPR is negative, then you're supposed to do a TPPA or another test, an FTA, whatever you have. If that's positive, okay, you have an EIA positive, an RPR negative, a TPPA positive. Remember that slide I showed you with the declining RPR titers over time? Well, you might be in that situation. So you have to decide, is it past, is it current, is it present? The clinician has to look at the patient and figure out what's going on, talk to the patient. And if it's negative, syphilis is unlikely. And that disturbs many people, that unlikely, because no one likes to say, oh, well, you probably don't have syphilis. That's not a good sentence. So anyway, the CDC said, okay, let us look. And if you're interested in this MMWR article, it came out February 11th of this year, and I'm going to just read the outcome, the data from 5 laboratories throughout the United States that tested over 140,000 serum specimens with this reverse sequence syphilis screening algorithm, indicated that among patients with a reactive EIA, 57% had non-reactive, let's say, nontreponemal tests, non-reactive RPRs. And among these discordant sera, anywhere from 12 to 60% were non-reactive with another treponemal test. So it suggests that they were false positive. And this was not a happy place for anyone to be. Now, this has been debated many times on the webs and in the literature, but I'm just going to say what the CDC is now saying. CDC continues to recommend traditional screening using a non-treponemal test followed by a reactive, if it's reactive, followed by a treponemal test. And you can read this. This will be up. You can read all the specifics. Here's what we do in Maryland. We do an RPR. If it's non-reactive, we stop. It's qualitative, positive, negative on the serum, done. If it's reactive, we start to quantitate. If we start to quantitate and it's completely negative, we stop. If the quantitation, however, the 1 to 2, 1 to 4, 1 to 8, etc., is positive, then we go on then to an EIA. And that's how we stand here. So your local health department in the syphilis diagnosis is coming up back. Who's your best friend? Your local health department. This came up wrong, backwards, but hey, we're talking about reverse diagnosis, so this makes total sense. Really, if you're in a quandary, you don't know what's going on, you don't know what these tests mean, find the number and call them up. This is their job. They're highly interested. I can tell you the state of Maryland and Baltimore City is. I can't imagine why DC wouldn't be, etc. So find that number and call up. It's the law. This is the same thing that I was talking about. So it's not only, I say, if you're a clinician, you say, oh, the lab reports all that stuff, I don't need to. Think again. Pay attention. You're the one that's filling out the lab form. You have to have the right information. Because if we have an outbreak in a certain area or region of the state, whatever state you're in, the health department wants to know where the person is, what's the characteristics, how do we stop it, how do we find people to stop the spread. Okay, this is what our state of Maryland confidentiality morbidity report looks like. The web address is on the top. It may look laborious, but actually if you read through this, it's pretty simple. And this is the second part. We have HIV, we have sexually transmitted disease, tuberculosis, it's all there. So this is the reportable diseases form. You can access it on the web. Please do, and fill it out to the best of your knowledge. It makes our job easier. What about preventing congenital syphilis in Maryland? Well, this is the General Health and COMAR recommendations. All pregnant women shall be screened serologically for syphilis a minimum of 2 times during their prenatal visit. At the first prenatal visit and the 3rd trimester at 28 weeks of gestation or as soon as possible thereafter. Now, when you read the CDC treatment guidelines, they say no infant should leave the hospital without that maternal serologic status having been determined at least once during pregnancy. And any woman who delivers a stillborn infant after 20 weeks gestation should be tested for syphilis. And the fetus should be tested for syphilis using a confirmatory test, if we have it. Serologic testing should be performed at delivery in areas where the prevalence of syphilis is high or for patients at risk. We are doing this here. We rank #1. We are doing it here in Baltimore. But I'm telling you, pay attention to how much syphilis is in your community and don't assume if you haven't looked. Ask questions of your patient. You have congenital syphilis we should not have. So be careful. All right, let's talk about prevention. Who should be screened? All pregnant women should be tested at their first prenatal visit for women in high-risk area groups. And I'm telling you, you know who you are or where you live, the clinicians that are listening. If you don't, find out. Repeat serologic testing may be necessary in the 3rd trimester and at delivery. Populations at increased risk for syphilis, as determined by incidence rates. Who are they? Okay. Men who have sex with men who engage in high-risk sexual behavior. If I'm a man who has sex with other men, MSM, and I come in to see you and I'm not having sex at all, okay. But if I come in to see you and you say, you know, Andrew, I'll be Andrew, how's your sex life? I say, it's great. I just met somebody new. Screen me. And if you say, okay, where'd you meet him? On the internet? Screen me. Okay, commercial sex workers, persons who exchange sex for drugs, and those in adult correctional facilities. Usually high-risk takers. It's an opportunity to screen. Hopefully that will be easy. And these are the U.S. Preventive Services Task Force recommendations. You can look them up. These were July 2004. I haven't found any more up-to-date than these. But if you find some, please send them to me. And this is what the Prevention and Partner Services. Now, that's screening, but let me spend a second on this. Prevention, we talked about prevention. Screening is prevention. Treatment is prevention. Talking to partners about sexual activity and treating them before they become contagious, if you can, is partner services, and that is rudimentary to prevention. Okay, well, what are partner services? What is this? Partner notification. It's a process through which infected persons are interviewed to elicit information about their partners who can then be confidentially, and that's the key, confidentially notified of their possible exposure or potential risk. So let's pretend that I come to see you and I have secondary syphilis, and you say, Anne, how many partners have you had in the past 6 months? And I say 10. You say, well, can you remember who they are or where they are? And I can give you some information. Let's say I specifically know Joe and Pete and Sally and Luis. And you know where they are, where they are. You're not going to say, okay, Luis, Anne named you as syphilis. No. You're going to say, hopefully find these people and say, we have reason to believe that you've come in contact with someone who has syphilis, and we would like you to come in and get screened and get treated. Now, usually people are very, open and willing to take care of themselves. And if you're the person that's delivering this message and they start screaming at you, who told you this? Say, this is confidential. I don't have any names here, but we do know that you're among those people that need to come in. So there's ways to do this. We can do it. We as clinicians can do it. But I'll talk about the disease intervention specialists who are your best friend, the health department, who will help you do this. We want to offer a range of medical, prevention, and even psychosocial services. We do this for HIV. It makes total sense. Why? To promote positive behavior change, reduce infectiousness, decrease STD and HIV transmission, and reduce, hopefully, STD and HIV incidence. This is why we do this. This is why this is important. Well, beyond you and me, who else does this? The disease intervention specialists, your best friends who sit at the health department waiting for your call. Okay? And I'm sure there's some of you guys that are DIS listening and you want to take out a knife and stab me, but that's okay. These people are trained to interview persons with HIV and other STDs. They know how to do this, and we call this the index person, and to elicit information about their partners and their associates, and to notify the partners of their possible exposure, ensuring that the partners are offered or know where to get appropriate services, which includes examination, treatment, and other referrals. So if I'm an injection drug user and I'm a partner, I mean, hopefully you'll go to the right place where they'll say, okay, Ann, we need to get you screened for syphilis, we need to get you treated for syphilis, and how about your drug problems? You want to go someplace to talk to somebody about this? You need to have all of this. This is healthy people. This is prevention. And also provide prevention counseling to index patients' partners' social contracts, meaning, that's wrong, social contacts, and associates. You know the social network? I didn't have sex with John, but John and I are really good friends, and we both had sex with Mary. That's a social contact. So maybe they need to come in too to hear some of these messages. And we were moving toward social networking for disease intervention of many types. Okay, so remember, lab reporting does not negate our responsibility as providers to report STIs to the local state government, because labs, they provide what we give them. So they have minimal information. So if the health department, let's say you send it off and the health department calls you, please don't take this as an offense. The health department is trying to figure out what's going on. Was the patient treated? Do I have to find them? And so please respond to avoid the health department ensuring that treatment is not delayed. The faster we learn about primary and secondary syphilis, the faster we can intervene and stop transmission. You might say, well, HIPAA doesn't allow me to do this. Yes, it does. HIPAA allows release of patient information for public health purposes. This is a public health intervention. Please cooperate. I am finished. I hopefully finished early and we can take some questions. There are many references that are peppered throughout the slides, but the main reference is the CDC Prevention and Control. This is the National Plan to Eliminate Syphilis, but also go to the cdc.gov/STD website. You can look for syphilis specifically, and it'll have a lot of handouts and a lot of great information, and the new treatment guidelines are there. So please do. Now, we're open to questions. Do you want to start here? We'll start in the audience first. Yes.
About 3 weeks ago, there was a patient treated at the Hopkins ER for a rash and was treated with prednisone. And my question is, what do you think are the possibilities of funding and having stat labs in the ER?
The question is, what is the possibility of funding and having stat labs in the emergency rooms, in the emergency department? Oh, yeah. So this was based on the fact that one of our HIV-infected individuals came in with a rash and No, just walked in with a rash, and they were treated with steroids because, All right. Again, one of the reasons why I'm preaching here, and maybe many of you are among the choir, but hopefully this will get out to emergency departments and to places which are thinking about many, many things. When you're in the emergency department, you do see a lot of rashes. But what we want people to do is think beyond the box right now, thinking that rashes, syphilis. Ask some questions. Is it a man who has sex with men? Is it a commercial sex worker? Is it an IV drug user? Or is it someone, who is connecting with high-risk populations? Maybe I'm not a man who has sex with men, but maybe I'm someone who has run across that social network where syphilis is. The easiest thing to do, if you see a rash, which dermatologists always do, send off an RPR or VDRL or whatever the screening test is. Would it be brilliant to have that stat? I mean, STD clinics have stat RPR tests. Yeah, it would. But I don't know if we're going to go there right now. I think what we're trying to do is come up with better point of care tests that do not require special microscopes or a long time. In other words, point of care, which they have in Africa, take a little stab of blood, put it on the magic card, add the elixir positive negative, just like a urine pregnancy test. And that's what we're trying to evolve toward. Dr. Charlotte Gatos is here looking for people who are interested in doing this to contact her. Any good ideas? Please let us know. Thank you for the question. Yes?
Sorry. I missed the first part of your talk, and I don't know if you addressed this population at risk that a lot of us are concerned about, which is minority men who have sex with men, particularly in Baltimore City and cities like
Indeed,
Baltimore.
I did. I drove that home. Good. So you'll be very happy when you see my slides. We have to pay attention. You know, minority men who have sex with men also may be incredibly hard to reach populations because of discrimination, not only within their community, but in the community as a whole. And we have to be aware of that. And actually, if there's anyone working with minority MSM, our health departments are very interested in collaborating with you all to get a better, I'm going to say, conversation going so that minority MSM don't feel as stigmatized to come in and get treatment and be aware. So, yeah, good point. Thank you. Yes.
What is your recommendation, given the delay of conversion from negative to positive on RPR? A person who presents with like chancre or something, recent exposure hasn't been the 21 days.
So the question is, for those of you on the web, what do we do? What is my opinion on someone who may come in to see you? Let's pretend you're in the emergency department or the STD clinic or the HIV clinic, wherever, with an ulcer or a chancre, what looks like a chancre, you know, there's not enough time for the RPR or the VDRL to become positive, or for that matter, even the EIA if you're doing reverse testing. You know, what I was taught in Seattle is treat and sort it out later. And, you know, I think that is a great thing to do. Now, okay, it's shots, 2.4 million units of bicillin, but it's also doxycycline. If they say, I don't want a shot, don't give me a shot, you can still do doxycycline for 2 weeks, 100 milligrams twice a day. Don't use azithromycin. Africa can use azithromycin. We have too many cases that have been reported with resistance to azithromycin by DNA probing. So, yeah, treat and figure it out later. And you will have sent the serology, but if you have somebody in the emergency department and they have an ulcer or chancre or a zipper cut or a bite, and you're thinking, treat. Okay, thank you. Any other questions? Yeah, we do.
So what would be the difference? I know the city health department immediately reports to the state, and you showed the graph with a large number of the cases being non-STD clinics. So what would be the difference in the reporting lag from, say, a private clinic compared to a STD clinic?
That's a great question, and I'm actually going to defer to Barb to answer that. But I tell you, it's an issue. It's an issue if you don't report quickly. And now I know the labs have algorithms for reporting, correct, Barbara? Yes. And they try to report as quickly as the tests come up positive. The lag is when there's not enough information that the laboratory can report to the health departments about the case. So, for example, I did a review for HRSA and various and sundry cities throughout the United States, and there was this one hospital. It's not Johns Hopkins, so you don't stone me here, but I'm not going to say which hospital. There's one hospital that said it's sent directly to the lab sends directly to the health department, and the question was, well, how did the health department get back to you? Because although they were saying, Miss Ann from such and such place, the health department couldn't get back to the clinic. There was like 12 OBGYN clinics within this institution, and they didn't write down enough information as to what clinic, who's the doctor, who checked. So therein is a lag. So me preaching to the choir about please fill out the forms, because that cuts down on the time. Because if we don't have enough information, somebody has to be aware of that. They have to say, okay, Miss Terry, you're the disease intervention specialist who's assigned to this case. She has to get her case. She has to find the person. She has to call on the phone. They have to return the call. Therein is the lag. And one other thing I will say, if you have somebody in the hospital who has secondary syphilis, please call your health department and tell them, Anna's here, she's HIV infected, she has secondary syphilis. That really speeds it up. Because I can come to the hospital and you, the DIS officer, can come to the hospital and interview me, Anne, who has this HIV syphilis co-infection. It really speeds things up, because if I leave, the DIS officer has to find me, and I may not want to be found. So that really helps. Yes, do we have any questions from the web? You want to come here? Oh, no, we have another question here. Yes.
I'm sorry I missed the first part of the talk, but I work with adolescents, and so I'm wondering, from what I understand, it doesn't affect them as much as the other STIs, and I just want to double check outside
please.
of MSMs who might happen to be adolescents.
Right now we are seeing increases among adolescents, meaning like the 15 to 19 to 20 to 24-year-olds. These are the ones that are increasing most aggressively. And that, especially among, minority, and they may be MSM, but also in the girls. And that's disturbing. So we have to be aware of that. And that's why, you missed it because I had my tick-off list on who to target, and adolescent and young adults are right in there with MSM, and we have to be aware. So yeah, please keep that in mind. Because, adolescents don't think they can get anything. Unfortunately, they do. Yes. No more in-house. Can we go to the web? Do we have any questions?
We have one comment.
We have one comment, which we shall. Just want to say thank you for the last comment about HIPAA. I'm in California. Yay, California. And here providers say they can't release that info due to HIPAA. No, this is on the CDC website. This is a public health concern. HIPAA does not apply. Are we good? Yes, another question here in the audience.
What brought about the change from STDs to STIs?
The question is, what brought about the change from sexually transmitted diseases to sexually transmitted infections? I think it was around stigma. People don't want to be told they have a disease, whereas if you have an infection, it can be cured and you can move on. So I think that was the whole politically correct move, and it's not a bad one. I trip up on all of them because I'm an old timer and I was taught disease, so sometimes I can't remember infections. Okay, well, I think we're right on time, 1 o'clock. Hopefully everyone in the hinterlands has had a good lunch, and thank you for listening, and thank you all for being here today with me. All right, remember, it's STD Awareness Month. Get yourself tested. Okay.
Thank you, Anne. Informative and stimulating as ever. I'd like to do a few wrap-up comments here, and this is kind of like the post-game summary of what did we just see, what did we just hear. So Anne was giving, and will say, Anne, every time you said your best friend, the local health department, I smiled. It was like, yay, because that's a very true, but also it's a relationship that I know that we work very hard at the state and local level to work with private providers to promote that relationship, because that relationship is what makes it so that we can intervene on a timely basis with our public health actions to try to reduce transmission. But a few highlights from Anne. That most cases are reported from non-STD clinics. So the private sector testing and screening are extremely important to us. And we really want to encourage additional screening and testing in private sector. STD clinic, we know, hey, you walk in, you've self-selected, we're going to test. But sexually active youth and adults who go for other kinds of healthcare services, it takes being proactive by the healthcare provider to ask that challenging question, how's your sex life, and open the whole conversation so that it can be determined if there is a need to do screening. There's some good tips on that, how to ask the question on the website, www.gyt.org, and that's to get yourself, used to be just tested, but now it's get yourself tested, get yourself talking. And the get yourself talking part of that is for youth and youth to talk with their partners, or anybody to talk with their partners, for people to talk with their healthcare providers and providers to talk with their clients. So it's just the whole thing of, can we talk about this and make it something that's easier to identify and to test for. Reporting, of course, very, very key part, and definitely appreciated the emphasis there on it's okay under HIPAA. And I would suggest that providers also tell their staff, because I know that they are the front line between the local health department and the provider's office. That's who our DIS call, that's who they interact with, is your staff. So if you can tell your staff, hey, local health department will call and it's okay to talk with them, and here's the information it's okay to provide them so that they can do their public health work. And then the final area of great interest and always lots of intrigue is the test analysis. And the recognition that there might need to be multiple protocols or sequences out there, in recognition of things like economic reality. But it can sometimes make that harder for the provider. You don't get to choose. You don't get to tell your private sector lab, oh, I want you to run it this way. They're going to do what they got to do. But if they're using the traditional sequence, great. If they have switched to the new sequence, there might be some things that you as a provider have to pay attention to. You might have to order the confirmatory test specifically. Some labs aren't doing that automatically anymore. And you might need to follow up with your lab to make sure that they're doing the confirmatory on a timely basis. So it just gets interesting as we go through all these changes. So again, I'd like to thank Anne for her wonderful presentation today, and thank you for your participation. Please be sure to fill out those forms so that we know who's been with us today. And if you want to mark your calendars in advance, next year, Wednesday, April 18th, 2012, that'll be our next cooperative effort here with the Mid-Atlantic Public Health Center and Region 3 PTC. Thank you. Click a slide, they're saying. The arrow key. No, probably not that one. There we go. Okay, on to continuing education credit. So there's your information for getting your continuing education credits. And there are several slides about that. And that's it. So thank you. Oh, that's our friend, the treponeme. I hear. Thank you.